Recording. Let the recording pause. Lights.
Yes, sir, sharing one.
Full screen, please. Can you make it full screen?
I made it full screen, sir. It is not visible.
इधर तो नहीं आ रहा. So let me welcome you to this 121st episode of Thursday Musings. A very important clinical topic, what to do when clozapine is not working. So we have a very, very sincere person to present this topic, one of the most dependable persons that I know of, my junior also. Next slide, please. So I'm handing over the session to Professor Dr. Tufan Pati sir. Sir is the chairman of this program. He's been quite a lot busy, but still finding time for us to guide us. And all the best, sir. And over to you.
Thank you, Dr. Lim. Before I start, I welcome on behalf of ANSIFS 2023 all of present over here and all your friends who are not present to ANSIFS 2023 to be held in Bhubaneswar from 2nd to 5th February 2023. Please come. Next slide, please. This is to introduce our vibrant moderators, Dr. Amrit Patujoshi and Dr. Alim Siddiqui. Both are professor of psychiatry in respective places. And Dr. Alim is the treasurer of Indian Psychiatric Society. And Dr. Amrit is direct is a member of Indian Psychiatric Society. Both of them are known as active members at IPS, as well as active moderators of this series. Next, please. Next one, please. Dr. Alim Siddiqui and Dr. Amrit. Next, please. Now, I have to introduce the chairpersons of this. Next slide, please. Dr. Samiksha Sahu. I have seen her in Bhopal when I went there last. She was totally vibrant from the beginning to end. She happens to be the daughter of one of my friends. She's quite, this is a personal appreciation for her. To introduce her, she's working as the assistant professor in GMC Bhopal, executive member of IPS Madhya Pradesh State Branch. She did her MDs from MD Psychiatry Gold Medalist and DNB Psychiatry, Fellowship in Child and Adolescent Mental Health, TNMC and BYL Nair Hospital, Mumbai. Advanced Certificate course in Management of Addictive Disorder, Nemens, Bangalore. Trained in Cognitive Behavior Therapy, Bex, USA. Lakshmi Sante Award for Best Female Researcher, more than 20 publications in national and international journals. BMJ Case Reports, UBS, also. Special interest in child sexual abuse, SLD. Welcome, Samiksha. Next,
Thank
please. Next slide, please. Dr. Prerna Gupta, young professor of TMMC and RC Moradabad, Uttar Pradesh, MD from SPMC Bikaner, MBBS from LTMMC Sion, Mumbai in 2003. Total experience is 13 years, publications 24. Member IPS Central Zone IACAP. Awarded PS Gellert Award for the best paper in 2008 in ANSIFS, Rajasthan. Welcome, Dr. Prana. Welcome, Dr. Samiksha. Hereafter, the meeting belongs to you. Please carry over.
Thank you, sir.
And next slide, please. Yeah.
Yes. Some of you introduce Dr. Siraz and
Yes, sir.
the other introduce the topic. Please manage between yourself.
So I have the honor to introduce Dr. Sriraj VS. Sir has completed his education from various prestigious institutes of the country. He did his DPM from CIP Ranchi. He completed his DNB from Institute of Mental Health and Hospital, Agra. then completed his postdoctoral fellowship from NIMHANS in clinical neurosciences and therapeutics in schizophrenia. Sir worked as an assistant professor in Department of Psychiatry in ADBS and CRC for neuromodulation and psychiatry earlier. And currently he is an associate professor in NIMHANS, Bangalore. He has been awarded with Best Paper Award at SIPCON 2013, Young Researcher for Second Best Paper in ICON 2014, ICMR Travel Grant awarded in 2017, WFSBP Young Investigator Award in 2019, ASHA Award in 2021. Sir has various research interests. He has interest in brain stimulation, transcranial electric stimulation, neurobiology of psychiatric disorders, psychotropic response, resistance effect. He has more than 7 chapters, more than 89 publications, and 4 are even in pipeline. He's affiliated to various organizations. He is a fellow of IPS, member of IPS South Zone, Central Zone, and East Zone, member of IPS Karnataka chapter and Jharkhand chapter, fellow of Indian Association of Biological Psychiatry, member of National Academy of Medical Sciences. We welcome you to Thursday Musings, sir.
Thank you so much, madam.
Now I request my co-chair to kindly introduce the topic.
Please stop the slide share.
Hello and a very warm good evening to all the senior persons, the chairpersons, the moderators, and all the attendees of this webinar. So today's topic is what happens when clozapine fails. So as we all know, clozapine is the first line treatment for treatment-resistant schizophrenia. But some studies have shown that 40 to 70% of the patients, even on clozapine, they achieve an incomplete remission. So these cases are referred to as ultra-resistant cases or clozapine-resistant schizophrenia. And the patients belonging in this category are probably the most severe patients suffering from this disorder. Now, with the current definition of clozapine-resistant schizophrenia still being far from perfect, the treatment of this disorder remains a formidable challenge. Although existing evidence has not proven conclusive with respect to the various strategies which are available to us clinicians for this condition, but some evidence does exist for augmentation with the antipsychotics, antidepressants, and mood stabilizers, and also ACT. So I hope that the eminent speaker for today will throw some light on the current standing of these strategies, and I will be really happy to hear what he has to offer. Thank you.
Thank you so much, Dr. Prerna and Dr. Samiksha. I hope my slides are visible.
Yes, sir.
Yes.
Yeah, and it's in full slide mode.
Yeah.
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 All the best.
Thank you. Thank you so much, Tufanpati sir, and I would also like to thank my beloved seniors, Dr. Alim Siddiqui and Dr. Amrit Patjosi sir, to having faith on me and offering me to be a part of this excellent webinar series that we are having, the Thursday Musings. And this is one of the area that I have been working for last 4 or 5 years. The patients who are having treatment-resistant schizophrenia, and the patients who are having clozapine resistance. Would like to discuss some of the understandings that scientific community or the medical psychiatric community that we have at this stage, and we'll try to understand how to proceed forward as well with this challenging topic. First of all, to understand, we all know schizophrenia is one of the topmost conditions which leads to disability across all medical and psychiatric conditions. And the recovery happens in only a subset of patients. It will be less than 20 to 30%. But even among those patients who show partial improvement, it's only 30% who will be showing response, and another 30 to 40% will remain completely treatment resistant and who might require clozapine. But even this huge population who will be receiving or who would require clozapine will not respond to clozapine all the time. It's only 40% of those who receive clozapine would finally end up showing adequate response to clozapine. And the non-response leads to severe and persistent symptoms like suicidality, increased aggression, relapses and hospitalization, poor functioning and quality of life, and there will be significant health costs that will be borne by both the society as well as the individuals and the caregivers. So we need to discuss and understand what we can do when clozapine fails, or we are not able to go ahead with clozapine, if not because of the failure, but many a times even due to intolerance. So these are the conditions which we call using different names: clozapine resistant schizophrenia, ultra resistant schizophrenia, super refractory schizophrenia. They may not necessarily mean the same. Sometimes when clozapine and ECT both fails, then term super refractory schizophrenia has been used. Nevertheless, what we try to understand is what to do when clozapine does not work, or what else to look for after clozapine. And there will be patients who might respond to clozapine, but there will be few symptoms which would persist and might not completely respond to clozapine. So let's try to understand what are such patients and how we have to delineate them and define them. So there used to be a lot of different kind of criteria that people were using, and that's one of the reasons why the science did not advance, because of a lot of heterogeneity in the definition of treatment resistance itself. So of late, the group, that is TRIP, came up and they have come up with this guideline on defining the treatment resistance in schizophrenia. Here, when they're defining the treatment resistant schizophrenia, there are 2-3 important points that we need to understand. One is the symptoms. So definitely the symptom improvement might not be as much as we will be requiring. The improvement in symptom, or the non-response to the non-responding symptoms, could be in any of the dimensions of schizophrenia. It could be positive symptoms, it could be negative symptoms. At times, the cognitive deficits and the affective and other symptoms which are associated with the core symptoms of schizophrenia might be leading to the disability. So when we need to understand and when we define the treatment resistance, we need to know what are those symptoms that we are trying to address. And the symptoms, it's not just that they should be present at some severity level. So the mild symptoms generally will not be considered as the persistence of the symptoms. So there should be at least moderate severity of the intensity of the symptoms to say that earlier treatments have not shown any response. And those treatments should have been given at least for 12 weeks. And they should be subject to distress, but it's not a mandatory requirement. And one more important thing, which we always should consider, is it's not just the presence of symptoms that matters, it's also the presence of dysfunction. There could be individuals who will be having significant amount of symptoms. If you talk to them, you might be able to elicit a lot of psychopathology. Nevertheless, if they are functioning, if they are not distressed, then we need not actually over-treat them, right? So these are about the current symptoms which are there in the patients. But at the same time, the adequacy of treatment is also equally important when we talk about the treatment resistance. It's about the past treatment, it is the duration of the current treatment, it is the dose with which the treatment has been given, and the total number of antipsychotics that were given earlier, and the adherence to these antipsychotics, which are clearly understood in some of the methods. Like it could be using the methods like counting the number of pills that were prescribed or dispensed, or reviewing the charts for routine follow-ups, the report from the patients, as well as the caregiver, and other monitoring levels like monitoring the plasma levels of antipsychotics. And equally important, as I was mentioning, is about understanding the symptom domain. So the TRIP guidelines actually encourages to specify which symptom domain is resistant to the treatment. It is positive, negative, or cognitive. And another important part that comes up in TRIP guidelines is also about specifying the time course. That is, how long was the duration for development of the treatment resistance from the period of onset of the first antipsychotic trial. It could be the early onset, middle onset, or late onset. We try to understand why it is important in the future slides. But when we consider this, so the ultra-resistant schizophrenia or the clozapine resistant schizophrenia has to meet the similar criteria what has been followed to define treatment resistance, and over and above that, there should be resistance to the clozapine. And when we say the person is resistant to the clozapine, we have to consider these three important points. One, the clozapine levels. The trough clozapine levels has to be more than 350 nanograms per ml, or the equivalent doses have been given, because clozapine levels are not easily available for everyone to understand or to get it done. So even if it is not available, at least the dose equivalent, which is known for the given population, at least the kind of a dose, the minimum dose has to be given, and the dose has to be given for at least 3 months. There have been a lot of controversies regarding what is the minimum duration that is required. Some people say it is 3 months, some people 4 months, even up to 6 months or 12 months have been defined, but TRIP guidelines stands at 3 months as some conservative criteria to go ahead and use it for future purposes. So when we're looking at the trials and evidences, how many of the studies or the trials that have gone have been compliant to these guidelines, or if not at least TRIP guidelines, the earlier guidelines that have been placed? If you look at it, it's actually very less. So we need to be cautious while generalizing the results, whatever we'll be looking at in the future. And hopefully we are hopeful about the future where people will be trying to be more compliant to these kind of criteria in their future research, and we might be able to get better evidences in coming days. Nevertheless, with available evidences, how can we go ahead? So first, whenever we have to talk about resistance, we should always remind ourselves about pseudo-resistance. We know pseudo-resistance comes with its own set of factors and attributes. It could be related to the patients, could be related to the treatment, or could be related to the illness itself. We should not get confused if an individual had poor pre-morbid adjustment. Could be because of the personality disorder, could be because of the intellectual disabilities, or could be because of different psychosocial milieu that individual is coming from. And we should also be careful about understanding the psychosocial milieu that the patient is in and the factors which are affecting there, which could lead to think that the person is resistant, but he might not be actually so. Similarly, we should always think when we are considering resistance, recheck our diagnosis. Is it actually schizophrenia? Is it something else? Am I handling the same thing? Are the symptoms are just schizophrenia, or are there any other comorbidities? Are there any concomitant substance use? Or is there a possibility of organic brain disorders, brain lesions? Or there could be some medical comorbidities, which could be as simple as vitamin deficiencies, which could be leading to inefficient antipsychotic effects. So we should be cognizant of these factors before concluding that the individual is actually resistant to clozapine. And there could be treatment-related factors. It is primarily about the compliance. As I was mentioning, at least 80% compliance has to be noted in the previous 3 months before concluding a resistance. We should be also cognizant about presence of any intolerance. Look at the side effects, which could be masking the response, and we might be looking at it as a presence of negative symptoms. Rather, we might be actually be looking at the side effects of the medications itself. The dosing, the duration, the prescription might not be matching with what actually the person is taking. So we need to be looking at that. And there could be many factors like the drug-drug interactions, the problem with the bioavailability, or the problem in the opportunities for rehabilitation and recovery. All these things could be showing or masking as the treatment resistance. So we need to be mindful of these factors before going ahead. And when we're defining, we need to be sure about the adequate dose. But what actually is the adequate dose is the question that people are still trying to solve. A recent Cochrane review actually looked at multiple dose levels in the RCTs. So they looked at the trials which used very low dose, trials which used low dose, and the standard dose by defining using the 150 and 200 mg as the cutoff criteria. And most of these studies were definitely from Western population, not from Indian population. The importance of this we'll again try to understand now. But they all try to see that the serum clozapine levels was more than 350 micrograms per liter. And what they could see is that there was no dose-dependent effect actually they could appreciate in the efficacy of the antipsychotics. But again, there were a few limitations in this review with respect to the size of the samples of the studies that it involved and other factors, and again, the Western literature that it completely depended upon. But nevertheless, this is something which goes against the common dictum that we always understand, that there is a cutoff criteria for serum clozapine. But at the same time, we know that there is a lot of inter-individual variability, and that inter-individual variability is something is probably which is playing a role when we were not able to appreciate the difference there. Because at the individual level data, we were able to see that there is a dose-dependent effect or the relationship with the effect of the clozapine. So here, there are two important factors which play a role in determining the level of clozapine which will be getting into the brain, and which we'll not be able to understand exactly. So we'll be depending upon the serum levels of the clozapine. So there are two enzymes which metabolize the clozapine, which will lead to formation of norclozapine, which is an active metabolite, and there will be one more passive metabolite, that is clozapine N oxide, which will be generated. And the serum clozapine has to be estimated at trough level if we are trying to estimate that. And we need to do it at least after 5 days of giving serum clozapine, and at least after 2 to 3 weeks of initiating clozapine. That is 5 days of achieving the steady state or the therapeutic dose that we would be targeting at that stage. So with this, if you look at what all things that can actually affect the serum clozapine levels, we know gender is one important factor. Females tend to have higher concentration with even the lower doses of clozapine. Asians and Middle East Asians are someone which include Indians who have higher concentration. It's almost double that of the Western population. So the standards in the dosing that we follow with the Western data might not be equally applicable to our population. The inflammatory reactions, serious respiratory infection can lead to sudden deterioration or sudden increase in the clozapine levels, sudden deterioration in the metabolism. So we need to be cognizant of it and has to be aware when we are looking at serum clozapine levels, or even otherwise when we are treating a patient, to avoid any intoxication with clozapine. And also comorbid or co-prescriptions, as well as substances like smoking, tobacco, or cannabis, like any smoking, which will lead to polyhydrocarbons, or the caffeine intake. All these things can activate, either induce or inhibit the cytochrome P1A2 and cytochrome P3A4, so which can affect the metabolisms of the clozapine. So what we understand now, after so many studies which happened in India, Singapore, and many other Asian countries, and of late even in the Middle Eastern countries, that the dose that is required for Indian population is almost 40 to 50% of what is required for the Caucasians or the Western population. So here, the target dose need not be 250 to 350, which is always advised in the Western textbooks that we follow, but it could be much lesser. Like in the non-smoking females, the target dose can be somewhere between 120 to 175, and the smoking males, it can be, it need not be more than 250 to 300 mg per day. but this is for an average Indian smoking male and an average Indian non-smoking female. But there will be individuals who will be on either side of the spectrum. There are people who are very poor metabolizers who might require as low as 75 mg per day. And we have seen patients who have been maintaining pretty well even with 75 mg per day and would develop side effects if we go beyond that. And there are people who would be having so much of enzyme inhibition, or they are so fast metabolizers that we might have to give them even thousands of mg to achieve the therapeutic level. So when should we be checking for clozapine levels to make sure that the individual has received adequate clozapine? One, when we are thinking of optimizing the doses and we have reached the therapeutic dose, which is average, which is required for that average for that population. And if you want to look at if it is working or not, then maybe we can look at dose optimization. If there is a change in smoking habit, either increase or sudden initiation of tobacco or cannabis, or it could be stopping. So mind here, it is the smoking. It is not the tobacco or the cannabis per se which affects the clozapine levels, but it is the polyhydrocarbons which will be coming out of it. So it could be even the caffeine, which will be roasted and which will be using, which can have polyhydrocarbons, which can again have the same effect as smoking. So caffeine dependence can itself be a major factor which could be playing a role many a times here in altering the clozapine levels. And when we want to assess the compliance, we can use the clozapine levels. When there is a possible dose-related adverse effects that we are looking at, probably then we can go for checking the clozapine levels or investigating the clozapine toxicity, and looking at the patients who are particularly sensitive to the drugs, we might use it. But nevertheless, this is not mandatory to use, but though TRIP guidelines actually suggest that we have to go, but with a resource constraint settings that we have mostly in India, I don't think we should be going for mandatory clozapine levels at this stage. The evidence are not so forthcoming about the need for clozapine levels. Nevertheless, understanding the clozapine levels will help us in gaining insights like the dose insights that we have gotten recently. And in the last 1 to 2 years, there have been guidelines which have incorporated this necessity of giving a lower dose in Indian population and Asian population across the world. Okay, how else it will help? So what we know at this stage again is that 350 to 550 mg is something which is an optimal dose of serum level, which again is from the Western population. We don't have actual data to suggest that 350 to 550 holds true even in Indian population. Nevertheless, with the given evidences that we have, we will assume that that is how it is going to be. And with the side effects, at least with whatever the experiences that we have, this seems to be correct. That is more than 600 mg if you are going, then the risk of seizures increases. But if you are going more than 1000, then there could be other risks that could be increasing. So we might be cautious if we are seeing the clozapine levels of more than 1000. And we have to look at the liver function test to see if there is any major damage that has happened to the liver. And then we have to start reducing the clozapine, again, not very fast, but can be gradual, looking at the risks and benefits of that are there, and we can reduce it further down. What comes important is not just the clozapine level, but along with clozapine, we generally will be able to get to know what is the level of norclozapine. And norclozapine is one metabolite which has a little longer half-life than the clozapine. And it usually will be at the two-thirds the level of the clozapine level. So if it is around 2/3, then we are safe. Then we don't need to worry. But if it is less than 2/3 or pretty much more than 2/3, okay, then we need to be looking at what led to this change. So both can be because of the problem in the compliance, okay, because it is about the half-life. And it depends on when the patient has started taking it. It might happen that the patient restarted taking the medicine. So in the last 1 or 2 days, so the norclozapine level would not have picked up yet. Or it could be that he has not been taking for a long time. And that could also be the reason why the norclozapine levels should have been more than the 2/3 of the clozapine level. Okay, but alongside the non-compliance, we should also be looking at the other factors, primarily the smoking, which could be leading to the inhibition and altering the clozapine, non-clozapine levels, and the co-prescriptions that we could be giving. And it could also be the damage to the liver or other metabolic problems that could be there that could reflect the clozapine, non-clozapine ratio that will be getting altered because of these changes. Okay, so with this understanding about the clozapine, the adequacy of the clozapine, let us go forward and try to understand what happens and how does clozapine work. So I'll start with the basics. Sorry. To start with, we'll just try to understand the story of the dopamine, which we all know. I will just be revising. We know the mesolimbic pathway, the mesocortical pathway, and there are nigrostriatal pathway, along with the fibroinfundibular pathway and retinal amacrine cells. So these are the primary dopaminergic systems that we have in our brain. And in schizophrenia, there will be increase in the nigrostriatal pathway dopaminergic activity, and there will be reduction in the mesocortical dopaminergic activity. So what we do, sorry. So increase in dopamine, production of dopamine will be increased in schizophrenia, which will be leading to positive symptoms, and there will be reduction in the dopaminergic activity to the, which will be going to the receptors, which can lead to in the cortical regions, which could be leading to the negative symptoms. Sorry. So now what we do with antipsychotics, we'll just add the antipsychotics. They will go and block the dopamine receptors. When they block the dopamine receptors, the postsynaptic neurons activity will be reduced. So there will be reduction in the positive symptoms. Nevertheless, it will also lead to inhibition of dopamine in other regions, which will also lead to the negative symptoms or the extrapyramidal symptoms. So that's where we come to the second generation antipsychotics, which does not just block the dopamine, that is the D2 receptors, but it also has an effect on the 5-HT2. So 5-HT2, they are actually the receptors which will be there on the dopaminergic cells. So when you when there is a hyperactivation of the dopamine, so there will also be the 5-HT2A receptors which will be actually be inhibiting the dopaminergic activity. That might again be altered in patients with schizophrenia, and here there will be blocking of these 5-HT2A by antipsychotics, which will lead to enhancement. So in that sense, it will reduce the EPS and it will make sure that the dopamine activity persists to happen properly in the cortical regions. So this is how most of the second generation antipsychotic works. But clozapine, it is something similar to second generation antipsychotic with 5-HT2A, but it is somewhat special. Why exactly it is so special, we are not very sure. But what we definitely know is the D2 antagonism of clozapine is not as strong as other antipsychotics. And we also know that it's one of the dirtiest drugs that we have, that it has effect on multiple other receptors, which includes the muscarinic receptors, the adrenergic receptors, other serotonergic receptors. So how exactly it works is something which is still still a mystery, I would say. Okay, but if you try to understand what happens with the blocking of the dopamine and how probably the clozapine will be more effective. So the first theory which came up with treatment resistance was with respect to the dopamine supersensitivity. So in the patients who are receiving antipsychotics in the first episode, if the antipsychotics were given for a shorter period of time and the dose was reduced rather than keeping it at a higher dose which was required in the acute phase, then if there was a reduction that had happened earlier, the patients achieved better maintenance than those patients who received the same dose as they received in the acute phase. So this probably meant that the patients are developing supersensitivity. So that's why the psychotic symptoms are worsening in these patients, and the improvement is not persisting, and they are developing probably the resistance to the antipsychotics. So this was one of the mechanisms that was earlier thought, and clozapine is one drug which can actually help us in reducing the supersensitivity. And we all know the supersensitivity is primarily because of the increase in the receptors, the D2 receptors, which will be there in the postsynaptic neurons, which will increase, and that will further increase in the sensitivity of the neurons to develop psychotic symptoms. And with this theory, people came up with even clinical criteria to understand who are those individuals who might be developing supersensitivity psychosis. So one of the important criteria was there should be a rebound of psychosis within few days of stopping. There should be development of tolerance to these antipsychotics, and there should be presence of, or the history of presence of, tardive dyskinesia. So all these factors points more towards the supersensitivity psychosis. And clozapine is one drug which helps here, but there are few other drugs which have been found to be working in such subjects who are having supersensitivity psychosis. One such evidence is primarily with long-acting injections. The two, with risperidone long-acting injection, it has been shown that they are effective in treatment-resistant schizophrenia who had developed supersensitivity psychosis. Also, there are few literature which suggests that probably aripiprazole as well as quetiapine might be helpful in those patients. So this might be one thing that could be helpful in therapeutic armamentarium when we are not able to initiate clozapine and we are seeing the treatment resistance probably happening due to the supersensitivity. But if we are able to give clozapine and the clozapine has not helped those patients, in such patients, if we want to add quetiapine, it might not be a good move. Why? They could be increasing the anticholinergic side effects. So whenever we are trying to look at augmenting clozapine, or rather I would say combining, right? Augmenting is generally used to the agents which are not antipsychotics, and combination is the one technically which is the one which will be used when clozapine is added with an antipsychotic. So when we are encountering treatment resistance and we are trying to look at the options, the antipsychotic, addition of the antipsychotic is the most common option that we use, but we should not be looking at quetiapine, olanzapine, or chlorpromazine in this because of the high anticholinergic side effects that it could be coming up with. Though it might be equally helpful in some of these cases like supersensitivity psychosis or supersensitivity phenomena that we'll be seeing with treatment resistance. But what we need to understand here is there are other antipsychotics which could be equally helpful. That is amisulpride, which can even be able to, there are few suggestions that if we add amisulpride, we can even think of reducing clozapine. So the effectiveness might persist. And amisulpride is known to have effect on both positive and negative symptoms, though it is not beyond the doubt. And it is also known to reduce the hypersalivation that will be happening because of the clozapine. But the problem with adding amisulpride to clozapine is it can increase the cardiac adverse events. Aripiprazole thus becomes one of the favorite choice of most of the clinicians. It is known to reduce metabolic side effects. It is known to reduce the prolactin. It may be helpful in the positive symptoms and as well as depressive symptoms. And as I was mentioning, it could be helpful in dopamine supersensitivity psychosis. But the evidences are not as strong. So there are other agents which have been quite widely used because of its availability and the historical usage, like risperidone and haloperidol. They are quite cost effective, but they come with its own adverse effect burden, and the evidences are also a little questionable when it comes to the clozapine resistant cases. Ziprosidone is something which has been tried and very well tested, but of late it has gone to the sidelines because it has not been able to prove its efficacy beyond doubt. And it also comes up with the problem with the QTC prolongation, and there's a major cardiac problem that we will anticipate with the ziprosidone. Pimozide and sertindole also had some of the RCTs in the earlier days, and they were found to have some effect on the positive symptoms. So all these are options that definitely we should be looking forward to when we want to augment clozapine with some antipsychotic. Also, there are case series or case reports with the newer generation antipsychotics like pimavanserin, asinapine, blonanserin, lurasidone, And long-acting injectables are again coming up high in the list when people are trying to look at the options beyond clozapine. So what are the things that we should be looking for when we are looking at combining or augmenting clozapine? One, we should be using the agents which might have a complementary mechanism of action. Clozapine being such a dirty drug, it's always difficult to say that what is complementary and what is the same. But definitely what we should be avoiding is the anticholinergic side effect, but because it can lead to gastrointestinal, cardiac, cognitive, and many other side effects which are there with the clozapine. And whenever you are combining with antipsychotics or any other agents, we should always be aware of the high adverse events, and so we should be very cautious. And we have to be monitoring closely for any combination if they work or does not work for the 3 to 6 months, and within that period any augmenting agent should work, and if it has not worked, please stop it. Don't just continue these antipsychotics or the other augmenting agents if it not helped in 3 to 6 months time period. But if you look at evidence, what does evidence say with respect to positive symptoms? Augmenting, is it a good idea? It doesn't seem to be so if you are looking at augmenting clozapine with antipsychotics. Why so? Let's understand it in the coming slides. But at the same time, there is one more factor that we can always look at augmenting, that is the fluoxetine and fluoxamine combination. It's a dangerous move that we could be taking, but it's not an option that we should always be ruling out. How does fluoxetine or fluoxamine augmentation works? It actually enhances the clozapine by altering its metabolism. So as I was mentioning, there is a clozapine and there is norclozapine, and there is a ratio of the clozapine and norclozapine. Both are active metabolites, active agents, and the problem with norclozapine is it is something which is related with higher rate of sedation, more metabolic symptoms, and more bone marrow toxicity. The neutropenia risk is higher if the norclozapine levels are higher. But it also comes up with some benefits. That is, norclozapine is better than clozapine with respect to partial M1 agonism, and primarily when it acts on the medial prefrontal cortex, it improves the executive functions. It is also known to have causing lesser orthostatic hypotension. So based on the kind of effects or the side effects that you are trying to handle, you might want to have higher or lower clozapine to norclozapine ratio. So when we add the fluoxetine or the fluoxamine, the SSRIs, it can be used to increase the tolerability with respect to sedation, metabolic problems, and other side effects. So it can be used because they inhibit the metabolism and it increases the clozapine to norclozapine ratio. Thus, they can be a treatment which can be used when symptoms are persisting and because of the intolerance, you're not able to go to the higher levels. The clozapine levels would not be reaching the 350 micrograms, but still you are not able, the side effects have been pretty much intolerable. The patient is quite sensitive. You can think of fluoxetine. The patient is also having comorbid depression or OCD and maybe the negative symptoms. So these are the cases where we can actually look at adding the fluoxetine or fluoxamine, but we should be extremely cautious in during these stages. Fluoxetine is still okay because it raises the clozapine level anywhere from 2 to 3 times. But norclozapine, it can go up to 12 to 20 times that has been reported with fluoxamine. So when you're adding fluoxamine, we need to be extremely cautious, and I would suggest please do monitor the clozapine serum levels if you are trying to add fluoxamine. So we try to look about antipsychotics. We also looked about antidepressants, that is fluoxamine and fluoxetine, but there are other antidepressants which would help for improving the cognition and negative symptoms, which includes the duloxetine, escitalopram, mirtazapine, and mianserin. Sorry for the spelling mistakes over there. But so these are all the drugs which are found to be quite helpful in augmenting clozapine, primarily in targeting negative and cognitive symptoms in schizophrenia. Also, we have mood stabilizers like lamotrigine, valproate, topiramate, and lithium, which would definitely help when there is an aggression, when there is suicidality, or when there is a affective dysregulation and affective symptoms which are predominating the manifestation in patients who are having schizophrenia and not responding adequately to the clozapine. But as I was mentioning about the evidences, the antipsychotics augmentation might not, or the evidences have not been so great, though we have been using it quite often. People started looking at why that is so. And when we are looking at, it's not just a dopamine supersensitivity, but there is a subtypes of dopaminergic activity which could be leading to manifestation of this treatment resistance and the effects of clozapine and non-efficacy of the clozapine as well. Okay, so what are these dopaminergic subtypes? So in the first episode psychosis, when people looked at the brain or the PET scans of the individuals who are having the first episode psychosis, people were able to make out two different types of patients. One patient which has a classical variety, where there will be increase in the dopamine secretion and excretion from the presynaptic neurons, which will be leading to the hypodopaminergia in the postsynaptic neuron and the synaptic left, and which will be leading to the psychosis. And these are the patients who generally respond well to clozapine, to any other antipsychotics, the first generation or the second generation antipsychotics. But generally, the patients who develop treatment resistance, so they are found to have normodopaminergia. That is, they will not be having this excess dopamine secretion, but probably the problem is somewhere happening in the signal processing, which are happening at the postsynaptic level or somewhere beyond this stage. Okay, and these are the patients who generally do not respond to the first or second generation antipsychotics, and these are the patients who generally become treatment resistance. But understand, these are the patients who become treatment resistance in early course of the illness. As I was mentioning, the TRIP guidelines now tries to look at the time course of treatment resistance. Early, which is that resistance developed within 1 year, middle, which is the resistance which is developing within 1 to 5 years, and late, which is more than 5 years. Nevertheless, this is some arbitrary cutoffs that people, they have kind of told us now, but there are early evidences where one of the studies by Yoshimura, he suggested that the 2.8 to 3 years is a critical window. So if the individuals have developed within that period, they might be responding well to clozapine. If the treatment resistance was more than that and clozapine was started after that, they might be the individuals who might be becoming resistant to clozapine. This might also mean that these are also the individuals who did not, in the beginning, did not had the normal, that is the normodopaminergic schizophrenia, but they had some other mechanism than what it is here. Okay, so then what are those other mechanisms which could be playing a role? The most common or most well-known hypothesis is with respect to the excitatory inhibitory imbalance. In schizophrenia, there will be disturbances in the vesicular transporters, the glutamate and monoaminergic transporters, and this transporter dysregulation lead to differential activation of the dopamine 1 and dopamine 2 like receptors. If we go back and remember, the antagonism of dopamine is not very high with clozapine, and it acts on dopamine 1 receptors. Probably that is the reason why clozapine is effective in some subtypes of patients, right? So here what happens is this dysregulation and activity differences that are happening in this subset of patients who are having schizophrenia would be leading to the differential involvement of the GABAergic inhibitory tone. Okay, and this glutamatergic activity and the GABAergic activity will be leading to the dopaminergic hyperactivity, right? So as I was mentioning, the differential activation of the dopamine 1 and dopamine 3 receptors and their signal, the further the transduction molecules. So they will be leading to resistance, and they will actually be altering the dopaminergic, the NMDA receptor activity. And NMDA is something which is quite important for long-term potentiation and long-term depression, and which are important for neuroplasticity and other activities. Clozapine has a special activity directly on the protein kinase and some other systems that are required. That is, for NMDA, we all remember, if we remember how NMDA acts, it requires magnesium as well as the amines, right? The glycine. Okay, so these all three molecules has to happen at the same time for the NMDA activity to work properly. Okay, so the glutamate, the serine, and the dopamine, so all these will be playing an intermediary role here in development of resistance, and the clozapine might be altering this system. So what actually happens when there is an excitatory inhibitory imbalance, which will be happening probably because of the receptor dysregulations or multiple transporter problems within the glutamate and the GABAergic neurons. So what happens here is the pyramidal cells will not be able to send the GABAergic, the pyramidal cells will be sending signals to the next level neurons, but at the same time, they will also be having a feed loop through the GABAergic neurons. So if the GABA does not fails to fire properly, then the feed loop will be lost, and there will be glutamatergic toxicity that could be happening. And this could lead to differential activation of the dopaminergic neurons, that is the neurons which will be going to the nucleus accumbens and the neurons which will be going to the prefrontal cortex, because of the, again, the intermediary role that will be played by the interneurons, that is the GABAergic neurons. So this GABA glutamate balance, and rather the imbalance that will be happening at the cortical and the subcortical levels could be the major pathology behind what we finally see in the final common pathway of the dopaminergic dysregulation. Right? So why does this alteration happens in the GABA glutamate balance? There are many theories, and most of the theories point towards the inflammation and the oxidative stressors. We all now know that starting from the maternal immune cells or the maternal immune molecules, the pro-inflammatory cytokines are much higher, and anti-inflammatory cytokines are much lower in patients with schizophrenia, their first degree relatives, and even during the prodromal phases. And it's been seen even in the developmental stages also. So in such individuals, there will be increased activation of the microglial cells, and this will be leading to oxidative stress and different metabolic disturbances, which could leading to the synaptic dysplasticity and leading to the positive negative symptoms and neurodegeneration, all the manifestations that will be happening. And why does this happen? This could be because of the inflammation or the infections, but it also will happen with the stressors. Significant stressor can lead to immune dysregulation, and the stressors can be at multiple levels. So all this can be leading to the neurodegeneration and the factors that could be leading here. So the final damage that will be happening on the brain is currently thought to be the oxidative damage, which will be leading to schizophrenia. And perhaps what we can see is these damage are controlled to a certain extent better by clozapine than by the first or second generation antipsychotics. And probably that is the reason why clozapine is the only drug known to have effect on negative symptoms, not on unlike any other molecules that we have at hand. So, but clozapine might not be effective in regulating all the problems that are happening at all these multiple sites. And so when we look at augmentation, we look at multiple other agents than the typical agents that we use. The agents which directly act on the glutamatergic system, the agents which act on the inflammatory systems, the agents that will be acting on some other receptors, which will in turn will be leading to anti-inflammation or glutamatergic activity, or directly acting on the dopamine also. And here, all these are the agents which have been tried and tested but in small number of population, in smaller RCTs, so the evidence is not very great. But the ones which are in red are the ones which are quite promising, and these are the some of the things which are coming up with the positive results in meta-analysis. And these are some of the things which we are using in our daily clinical use also. So those are the ones which have highlighted in red. Memantine is one agent which has been found to be effective probably even in positive symptoms, though we have been using it primarily in negative symptoms and primarily for the cognitive deficits. The lamotrigine topiramate has been working as one of the good agents, again, primarily because of their activity on the glutamatergic and GABAergic systems. Okay, so the D-serine, D-alanine has been found to be quite promising, but the availability of them to be used for regular clinical purposes are quite restricted. Riluzole, sarcosine, ampakine, they all act on increasing these glycine receptors on the NMDA and thereby improve the NMDA activity. So that's why NMDA probably is playing a major role in effectiveness of the antipsychotic effects. So thereby in handling schizophrenia, the glutamatergic the modulators are something which are found to be, which have been quite promising, but how exactly they are working and how much is the effectiveness is something that we don't know at this stage, and the studies are ongoing using all these different agents. Anti-inflammatory agents have been tried, and most of these have been used, like the colecoxib, which is an NSAID, the minocycline, N-acetylcysteine, omega-3 fatty acids, aspirin, even the estradiol, because we all know that estrogen is something which is protective in females, and that's where we'll be able to see the dual mode, the two modes in the age at onset in females, and particularly in females, estradiol raloxifene has been used and has been found to have promising results. Nevertheless, none of them have sustained the efficacy in any of the RCTs, like at least with NAC, omega-3 fatty acids, there have been large RCTs which have happened and has not been found to be effective at this stage. So we might not be able to recommend the regular usage at this stage. Allopurinol is one certain agent which works on the adenosine receptors, which we generally use for the gout. And the reasons I'm telling these are because these are the repurposed drugs. And many a times we might be using these drugs not for schizophrenia, but for some other comorbidities. And if we are cognizant of these agents and how they can be working, we might be able to use them for our clinical purposes and even handling the schizophrenia in such patients. And we might preferentially use these agents compared to other agents that could be useful for the comorbid condition that we would be handling. So allopurinol is one such drug which we have been using, and some of the patients do really respond well, and it's one agent which is not having much side effects. Here the adenosine receptor actually works like your 5-HT2A receptor on the dopaminergic neurons. So it works like the adenosine agonist works as a dopamine antagonist, and dopamine agonist, adenosine antagonist work as a dopamine agonist. So it has been used, allopurinol is being an agonist, has been used in schizophrenia and has been showing some promising results. Similarly, there are retinoid receptor agonists, there are calcium channel blockers, there are H2 antagonists which have been used, but there have been few small RCTs which have been positive, but there are similarly smaller number of RCTs which have been negative. Ondansetron is one agent which again has been used in schizophrenia as well as in OCD through its 5-HT3 antagonism, and probably might be useful in those for having negative symptoms and cognitive deficits as well. But going back to the evidences, this is one of the recent evidence, which is a network analysis, which is yet to be published. I think it's still in press and it's available online, where they looked at all different augmenting agents that were used with clozapine. And they were able to see that none of the antipsychotics work as an augmenting agent. And this is not the only study that showed. There have been series of meta-analysis which have happened in last 2-3 years using different kind of criteria, and none of them have been able to demonstrate the superiority of augmenting clozapine with an antipsychotic compared to the placebo with the clozapine, right? But what is coming up strongly is the memantine, as I was mentioning. right? So the memantine is something which has shown to have quite a significant SMD, and though it is a small effect size, but it is something which is found to be having good effect on the positive symptoms. Nevertheless, the studies are little less with memantine, so we need to be little cautious to completely believe this result. But what is also standing visibly ahead from all other modalities is ECT. We'll come to ECT at the end of the session. But when we looked at the negative symptoms, the persisting negative symptoms, so the refractory negative symptoms in patients who are receiving clozapine, so there are 2-3 agents. That is, again, the memantine is something which is coming ahead. Along with that, the antidepressants, primarily the duloxetine and mirtazapine, are found to be quite effective. Right, and CBT is also something which is coming forward, but again, after just recently there have been large CBT which has come up again. I think we'll discuss in coming slides on CBT. So how effective it will be is something which we still have to wait and watch. Nevertheless, the amisulpride clozapine is something which has found to be having significant acceptability with high consistency, and probably if we have to go for the combination with antipsychotic, the choice could be the amisulpride before going for probably even the aripiprazole. So with this evidences, so when we are seeing, except for 2-3 molecules, there is an absence of evidence. Should we consider this as just the absence of evidence, or it is the evidence of absence? It's quite early to say that there is an evidence of absence. So that's where we might not be able to rely completely on these trials or the meta-analysis, because the meta-analysis are basically based on the trials that were there, and trials had a lot of heterogeneity, as I mentioned in the beginning itself. And the results, the kind of study design, the rigorosity of the designs have all been questionable, and mostly they have been of very small sample size, which definitely brings down the value of this meta-analysis. And that's why probably we have to rely on the experts. And last year, the TRIP working group came up with a consensus guideline, right? I would say this consensus guideline, again, because of the kind of evidences that we have, was not evidence-based guideline, but primarily with the experiences that the experts had. And what are the recommendations that they had to give? If you look at the Maudsley guidelines, so most of the guidelines, they ask us to stop clozapine if it is not working, and mostly maybe it's better to go with replacing it with the alternatives for the clozapine. But the experts does not believe so. They say that it is better to continue clozapine in patients who are refractory. And the first step that you have to do is look at the clozapine levels and try to see if you can increase the clozapine levels, and do it twice rather than just once, and see if the consistency of the clozapine levels is being maintained. If it is not, then you have to look at all the pseudo-resistance factors. For those who have clozapine refractory, positive, negative, or mixed symptoms, the augmentation of clozapine with CBT and psychosocial interventions can be considered, because it is quite safe and does not have any major problems. But how much effective is, though it is questionable, they all prefer to go for this. For all combination or augmentation strategies, don't change the clozapine, don't stop the clozapine, is what the consensus was. And do not switch to other alternative pharmacological agent before finding the efficacy of the alternative pharmacological or even the neurostimulation agent. So you might want to give them as an add-on agent. And there are some smaller evidences which are present which suggest that clozapine with ECT probably works better than clozapine or ECT which are given alone, right? So with these, the following recommendations are being given. And they also came up with this recommendation, that is, when you are seeing a patient who is having clozapine refractory positive symptoms, go for it. Go for combining with another antipsychotic, preferably amisulpride or oral aripiprazole. And there are newer other agents which are coming up probably, but the consensus was for primarily these two agents. The best, again, is always the best. That is the augmentation of clozapine with ECT whenever it is possible. Clozapine with refractory negative symptoms, go with an antidepressant. If there are mixed symptoms, again, go for antipsychotics. Probably aripiprazole would come first, then amisulpride here. And again, ECT can be a choice. If there is aggression or suicidal ideations, go for mood stabilizers. Or if there is suicidal ideation, antidepressants can also be tried, and keep ECT always in your armamentarium. So when you are combining or augmenting agents with what we generally use, so look for the symptoms. If it is antipsychotics, if it is positive symptoms or aggression, see if you can go for antipsychotics. For mood stabilizer, if you're going, then it will be good for aggression or suicide. And for negative symptoms and suicidality, probably the antidepressants would be a better choice. Okay. So then if the consensus was not to stop clozapine, so then should you not stop it? The de-prescription is not at all recommended. That need not be the case. We should still be considering de-prescription, but it might be in a very small subset of patients. And that should be considered at an appropriate stage when there has been a good response with certain agents. So the de-prescription should always be very gradual. Because if you reduce clozapine or stop clozapine, you will be risking the worsening of symptoms, again, because of all the withdrawal symptoms that it could cause. Cholinergic withdrawal, adrenergic withdrawal, serotonergic withdrawal, as well as the dopaminergic withdrawal. So always keep in mind that there are alternative therapies, and we can always look for alternative therapies. So to summarize, what are the alternative therapies that we have for clozapine? The modest evidence is for physical therapy, primarily the ECT, RTMS, TDCS, and deep brain stimulations are something which are again having emerging evidences which are quite promising, again, because they work on excitatory inhibitory imbalances, and they will be improving the neuroplasticity than just targeting the dopaminergic neurons. There are also evidences, though they are quite weak, in going with non-clozapine antipsychotic polypharmacy. The best evidences are there for adding amisulpride and clozapine, going with a combination of quetiapine and amisulpride, and maybe even the aripiprazole and olanzapine. Also, depending on the symptom domains, we might have to fine-tune antipsychotics, say olanzapine, amisulpride, with adjunctive antidepressants or adjunctive mood stabilizers, anticonvulsants, depending on the symptom profile that these individuals are having. Very weak evidences are there for monotherapy with non-clozapine antipsychotics in a higher dose, like olanzapine up to 60 mg, aripiprazole more than 45 mg. So all those things have been tried, and even with the long-acting injections, there are case reports and case series which are coming up, but rigorous evidences are still to be built up. Anti-inflammatory agents, glutamatergic modulators, psychotherapies, which I was been discussing. So they have very weak evidences, but nevertheless, it is not that we should not use them at all. We should be cognizant of them and try to see when and where it could be appropriate. So coming to the brain stimulation methods, as I was mentioning, electroconvulsive therapy is the one which is having the most consistent evidence to reduce positive symptoms as well as suicidality and aggression in clozapine-resistant schizophrenia. And ECT with clozapine is the best than giving only ECT without clozapine or only clozapine without ECT. The bifrontal or the right unilateral ECT has been found to be cognitively safer than bitemporal in patients with schizophrenia, but it has not been found, it has not been studied in clozapine-resistant schizophrenia. Again, the electrical parameters and which is better, which is not better, something which we don't know. But this evidence is primarily from one study by the Petridis in 2015, which was a blinded study. It was a single blinded study where only the rater was blinded. But there was one recent meta-analysis which actually came up, and this was from a Chinese group, and they looked at the Chinese registry, clinical registry, and they were able to accumulate around 11 studies. And that's where, because of this meta-analysis and the studies that they were able to aggregate, is why we are seeing such a big evidence gap, big evidence for ECT that are coming up in the meta-analysis. But we should keep this in mind, that all these studies were controlled with, or the control was the treatment as usual. It was not used with a sham ECT. So we will not be able to say for sure that the sessions, whatever we are seeing, the improvement that we are seeing is just because of the ECT. Nevertheless, the skepticism should be there for the scientific rigorosity, but for the clinical use, if I have a patient, I would definitely go with ECT as one of the best options that I have in reducing the positive symptoms in the patients. But looking scientifically, we need to go for sham ECT, and I think that's something that we have initiated now. It's a collaborative work that is happening at NIMHANS, CIP Ranchi, and KMC Manipal. We have started a sham controlled ECT for clozapine refractory patients or clozapine intolerant patients in schizophrenia who are having positive symptoms. We are trying to see how efficacious this study would be, and this is one of the first of the studies which will be able to help us in understanding the effect of ECT in this population. Alongside this, there are other neuromodulation therapies which are quite forthcoming, though they have not been absolutely seen with only clozapine-resistant schizophrenia, but they have been seen in patients who the studies included a significant subset of patients who had clozapine-resistant schizophrenia as well. So again, here it's primarily the effect of TMS as well as TDCS has been found to be effective in auditory hallucinations alone, not much in delusions. So when there is a persistent auditory hallucinations, either with or without clozapine, RTMS is something which could be helpful, where you'll be trying to reduce the excitability of the left temporoparietal junction. More than that, TMS as well as TDCS have been coming up with a good effect on the negative symptoms of schizophrenia. And here, the effects are quite promising, and we need to be quite mindful. And because of its safety, its usage has been increasing. Nevertheless, the rigorosity of the research yet to kind of take us to the stage where we can take them and tell them as they are the first-line treatments for either auditory hallucinations or for the negative symptoms and even the cognitive deficits in schizophrenia. So DBS is also one more thing which I think I missed including in the slide, where the SGSCC and the ACC has been targeted and has been showing some positive results in one or two small sample-sized randomized controlled trial. CBT and psychosocial interventions is something which we should never forget. CBT has the most literature. It's again harmless, but a large recent RCT was unable to show effect of RCT and effect of CBT in comparison to supportive care. So the structured CBT could not help, but we can still consider psychosocial interventions, which will help us in continuing the recovery process of the individual. Okay. So to conclude, individualization of the treatment is needed, and when it comes to clozapine-resistant schizophrenia, it's probably the art rather than just the science. And the foremost important thing that we should remember is we should not get into the therapeutic nihilism. And it's always that the proportion of individuals who respond to any medication would be less, but there will be patients who will be responding to one or the other. So we need to keep looking for the agent which can help us and bring the patient to a functionally recoverable stage. And we should always also be looking at not just focusing on the symptoms, but on the functioning. So the recovery with symptoms is one thing that we should always be keeping in mind, and it should not be ruled out. We should not be over enthusiastic in reducing the symptoms. Psychosocial rehabilitation thus will be an important aspect to improve the quality of care and quality of life of the individuals. And that's what we will be going ahead with. So with this, I would like to thank everyone. I would like to thank the team that is there at NIMHANS, the INSTAR team, the schizophrenia treatment and reintegration team, the translation psychiatry lab, the Visor neuromodulation program, the CRC, as well as the OCD clinic, which are all supporting me, as well as the funding agencies which have been supporting with some of the work that we are doing here. And I would like to thank all my seniors as well as my colleagues and the juniors who have been there with me in all these years, which has helped us in conceptualizing schizophrenia in a different way, that to primarily the patients for having clozapine resistance. Thank you.
Thank you, Sriraj, for a wonderful and a minute take of the topic. Over to chairpersons for their opening comments, and then we can proceed for the discussion.
First of all, sir, that was a very excellent and a thorough presentation. I'm sure everybody who attended the session have gained new insight into the topic, and you have covered each and everything, like no stone was unturned. There was just a couple of things which came up to my mind while we were listening to the presentation. Like when we talk about clozapine resistance in this country, not many physicians in day-to-day practice use a high amount of clozapine because there is a lot of fear regarding the monitoring and the side effects. And many a times, even which we have faced, that the patients with a lot of side effects with high dosage of clozapine, like a lot of siluria is there, a lot of constipation is there, and sometimes some patients developed seizures as well, not like frank seizures, maybe a little bit of myoclonic jerk. So that sometimes becomes a hindrance or maybe a roadblock in achieving the full effect of clozapine. So if you like to put any comments on dealing with the serious side effects. And one more thing regarding the smoking profile. There were a few questions in the comment box, like if you can define the smoker and non-smoker. So these were the 2 points which I would like if you can put few words.
Thank you for those nice words and appreciation of the presentation. And I think the questions are also quite excellent. If I have to take the side, and I think I will take the side of the clinicians or the practitioners. See, because we have been following books and we have been trying to push clozapine to the higher levels because of the lack of evidence that we had. But we have been seeing what happens on the field, and then the optimization of the clozapine doses. I would definitely recommend that we have to do that, looking at the risks and benefits that we will be handling in the patient. And we have gotten evidence now quite recently where all the international experts are also coming back and telling us, okay, what practitioners are practicing, use a lower dose. As I was mentioning, the doses that are required for Indian population is actually not as much as what is required in the Western population. So it should be the effects and the side effects which should be guiding us rather than just the blood levels or the textbooks. In that sense, I would definitely say that lower dose is not a bad practice. But at the same time, we should not be clozaphobic, as we have used the term in one of our previous literature also. That we should not be unnecessarily fearful of the side effects of the clozapine. We should be cognizant of the side effects, and we should be dealing with the side effects. If there are seizures and if the patient has not shown effects, and we are seeing that there are some effects which could be dose dependent, there could be some effects which might not be dose dependent. So we should be tapering the doses accordingly, and the seizures is something which is actually a dose dependent side effect. So if seizures are happening in an individual who is otherwise not having any increased risk for epilepsy, then fine. But if the patient had any underlying vulnerability for seizures, like it could be the patients are having intellectual deficiencies or some traumatic birth injuries, on so forth. So in those individuals, add valproate, it will, or add lamotrigine. They are excellent agents which can further enhance the effect of the clozapine. So then you can optimize even clozapine also. So we need not be worrying too much on the side effects. We should be cognizantly handling, but at the same time, yeah, I would not suggest that we should be just following the textbooks and blindly keep on increasing the doses. The linearity of the effects are not well substantiated in the sense after certain dose, like after 350 to 400 mg, like definitely after 600 micrograms per liter serum levels, further enhancement of efficacy is not found. Okay, so that would be my point on that. So with respect to smoking, yeah, that was a good question. So when to say someone is a smoker or someone is a non-smoker, like any amount of smoking can lead to induction. Smoking primarily, as I was mentioning, it is the polyhydrocarbons which will be causing the enzyme inhibition, and even as low as 8 cigarettes per day has been found to be leading to almost saturation of these cytochrome enzymes. That is, if you are going with 8 cigarettes per day, you will be able to see that 40 to 50% of change in the clozapine levels can happen. Okay, and that's probably is the maximum. So more than 8 also, it might remain the same. But till 8, probably there will be a linear effect that could be happening. Even a single cigarette can change the clozapine levels, but after 8, probably it's going to remain the same.
What about the siluria and the constipation? Sometimes on higher doses, it's a bit difficult to treat, and sometimes you have to reduce. And when we talk about augmentation of clozapine, you have to combine two antipsychotics, like if you're planning HPL, risperidone. Then again, these side effects exacerbates. So what will be your take on that, sir?
So yeah, choose the antipsychotics accordingly. If siluria is a problem, I would say probably we can go for something like amisulpride. Amisulpride has been found to be effective in siluria. So augment with amisulpride rather than going to the risperidone in such cases. And yeah, use glycopyrrolate or use the agents to reduce the side effects if and when it is so disturbing that the patient is actually having significant siluria, which is leading to problems even in the breathing or such kind of issues during the sleep. Otherwise, the first thing is, I think, reassurance and telling the patients from the beginning that there will be side effects with clozapine, and these are going to be the side effects. And don't worry, all these things are handleable. There are few side effects which could be disturbing, where we might have to stop clozapine, but there will be many side effects which should not be so much, and which we should be able to handle in one way or the other way. I think education is something which help patients in sticking to us, and then we might be able to take them forward in the therapeutic process.
Okay.
Thank you, Shreya. I think Dr. Prerna wants to, any comment from Dr. Prerna? Then we can proceed.
First and foremost, I would like to extend my heartiest congratulations to the eminent speaker, Dr. Sriraj, sir. This has been one power-packed hour. And I never could have imagined that in 1 hour, so much of information could be, summed up into. Being true to the topic itself, the pertinent topic for today, that why clozapine fails and what should we do when clozapine fails, you have also enlightened us about all the various conceptual questions about dopamine supersensitivity, psychosis. So I think this has been a boon for all the people who have attended this lecture. A big hats off to you, sir. Very nice presentation. And the take home point, I think, from this presentation, I feel is that although that there is no conclusive evidence, there is a large database of evidence, but there is no conclusive evidence, but that should not discourage us clinicians to try out individual therapies for our patient from the huge basket that you have laid right now in front of us. We should never feel, as you said, nihilistic therapeutically, and we should try to give maximum benefit to the patients. Thank you, sir.
Thank you so much.
Thank you. And if Samisha, can you help us taking some questions from the chat box, if that is okay with you?
So there was one question, if sham ECT would help in this, from Dr. Hemant Bilsare.
What do they mean? I don't get the question.
That was it. Is there any role of sham?
When you were presenting about ECT, the comment came at that time whether sham ECT would also help in such cases. That I couldn't know.
Yeah, we don't know. When we say sham ECT, because we are doing the study to understand the true effect of the ECT, so we are going to give the anesthesia and the procedure itself. There will be a lot of placebo effect that will be coming in place, as well as there could be effect of anesthesia and the other agents that we will be giving during the ECT that itself could be bringing in the bringing in some therapeutic aspects into the whole system of the patient care. So that's where sham ECT is the one which will be the rigorous point of examination. Nevertheless, for clinical, I would not say go for sham ECT. If we have to use, we have to use true ECT. Sham ECT will be only for the research purposes to definitely understand the effect of ECT.
There was okay, sir. Another question was at what dosage in Indian population should we say that the response is not adequate and we should start for augmentation or combining other agents with clozapine? That is a question from Dr. Khalil.
As I mentioned, I gave you the list of, it depends on what are the different factors which are there in that individual. It is not just the individual. Is it a male or female? Is it the elderly or an adult? He is a smoker or a non-smoker? Is he on any other medications, oral contraceptives, or antibiotics like ciprofloxacin and other agents? So all those things we need to look at. So there is no hard and fast rule. And despite all these things, again, there could be individuals who could be the fast metabolizers or slow metabolizers. So if you have an option at this stage, go for getting the serum clozapine levels, the trough serum clozapine levels, and use that and go somewhere between 350 to 550 as the target. And if it is, if the person has not improved with that dose, consider that as a clozapine resistance. You need not go further beyond that. If you don't have the facility to look for clozapine levels, then probably just look at the effects, the side effects. Okay, try to look at the dose-dependent side effects like the seizures or even the siluria, sedation. So some of these side effects might be able to guide us in reaching the optimal level of clozapine.
Okay.
Even tachycardia is something we need to take care of. You know,
Yeah,
we see very high levels of heart rate with. So that's one thing.
Yeah, I did not go to that. Again, tachycardia and myocarditis is something which is again coming up with the Indian population, and people are actually started suggesting that we should start with even lower doses, specifically for those people who, the females who require say 75 mg kind of a dose. Probably we might have to start with 12.5 or even less than half the 12.5 doses and go with the smaller increments, because myocarditis is something which is found to be dose escalation dependent, similar to how we see with lamotrigine. Myocarditis with clozapine is found to be dose escalation dependent. So that is something which is coming up. Again, it was not the core of the topic, so I did not go there, but something which we need to be thinking about when we are using clozapine.
Yeah, there is a question about two questions rather on memantine and N-acetylcysteine. So what dose, what duration, and how do they help actually?
Memantine is given at the dose of around 20 mg per day. You can give it BD dose as we usually give in dementia. N-acetylcysteine, people have been like, there is a large study which has come up, which has been negative, and till as of now, NSA has not been so promising in both our practice as well as in the research literature. So NSA might not be recommending at this stage. But memantine is something, yeah, it is around 20 mg. And this study has shown that it is, generally we use it for negative symptoms of cognitive deficits, but the recent network meta-analysis has come up and it has shown that it is effective in positive symptoms as well. So we need to see how it is going to go ahead in coming days.
I think Dr. Prerna.
Yeah. I think there is a very interesting query in the questions. Dr. Neha has asked that generally most of the second generation antipsychotics have already been tried before switching to clozapine. So in that case, what kind of combination agents should we be looking forward to? And if we have already tried risperidone and amisulpride, as you have said in that we should add those agents, should we again add it with clozapine or should we not think about it?
Prerna, I'll give a comment. Then we'll give it to Sriraj. The major issue with us is that when to start clozapine. I think that is the major area where we create a lot of resistance in our patients. We need not try every molecule to. That's where the therapeutic nihilism comes. That's where the treatment becomes more resistant. That's one area I think Sriraj should address. When we decide that clozapine should be the first choice, or clozapine, we should not wait for the criteria. We know that this patient is not going to respond to X molecule or Y molecule. Why not start clozapine? I think when to start and the pointers where we can start clozapine as the first line, not waiting for it to be the fourth line or the fifth line or augmentation or combinations is one of the important aspects, I think.
Yes,
I wanted to add to that question.
Yes, sir. I completely agree with Amrit, sir. Actually, the delay in clozapine initiation itself has been a major factor which has been attributed to the clozapine resistance. And more interestingly, the recent evidences have been quite substantial to say that even if a patient fails amisulpride trial, only single trial of amisulpride, clozapine is the one which we might have to be looking at. So the Morsley guidelines and most of the guidelines, they have actually come up with this, not for any other agents, primarily for the amisulpride. If there is a single amisulpride failure, not intolerance again, failure, when it has been given adequately for at least 1.5 to 2 months, if there is amisulpride failure, go for clozapine. Any other antipsychotic, as usual, we all know, 2 antipsychotics, we should not be waiting too long before going to the clozapine after that. Okay. One important thing, probably what we might want to add along with this, even the TRIP guidelines also tells, is probably we can look at long-acting injections. Because the compliance will always be an issue. So if you want to consider something, it's not just because of the compliance, I would say. It's also because of the bioavailability, which is something which we generally will not look into. The bioavailability will be an issue because we will not be again checking the serum levels for the antipsychotics. So many patients might not be getting the substantial levels of antipsychotics which they might require. So the long-acting injectables, which should be given in intramuscular format, might be more effective in that sense. So going for one trial of long-acting injections, I would not say go for second-generation antipsychotics. Go with even first-generation antipsychotic, but a long-acting injections before clozapine would be one thing that we can look at. But more than that, I think we should not be delaying just with the fear of side effects and the problems.
There is one concept of like, is there any way we could predict CRS, or like there are new things in the market like gene scan and all saying that this is the dose we would optimize it for the patient. Do you recommend anything like that, or is there any way we could predict?
The genetic tests that have come up, they have not been shown to be highly sensitive or specific. So at this stage, it's not recommendable for regular usage. They might be helpful in coming days once we have much larger data. What we might be able to understand is probably those patients who are fast metabolizers, those patients who are slow metabolizers, then probably we might be able to identify with these tests. And again, not all the patients will be able to identify, but at least a subset of patients who the problem is because of the specific genetic mutations, which will be leading to this enzyme dysregulation. So those people we might be able to identify, and there we might be able to optimize our dosing properly. But for the regular clinical usage, I don't think we are yet to that stage of understanding.
Okay, there is an interesting question. Which is the best drug for clozapine-induced seizure? Suppose we still want to continue clozapine. So will it be lamotrigine, topiramate due to augmenting effects? Any role of valproate, levetiracetam?
Levetiracetam, we don't have much data. Valproate is something which has been quite widely used. If there is an aggression, we always look at the patient holistically. Don't look at only seizures. If there is an aggression, I would say go for valproate. If there are affective dysregulation, if there are patients, if there are episodes of depression, or even subtle level of affective symptoms which are there, then lamotrigine will be a very good agent. But lamotrigine will take time, so we should be cognizant of all these things, and we might be choosing, we might go for adding valproate first if we immediately need to add, and then switch over to the lamotrigine. Those are some of the options. Topiramate, we might not be going ahead, like even for the augmentation, topiramate is used at a lower doses, usually at around 50 mg or 100 mg. For antiepileptic effect, it might require to be given at a higher doses, which might come up with cognitive side effects. So that's the reason topiramate is generally not used as an anticonvulsant agent along with the clozapine. Valproate and lamotrigine is the choice we might have to consider depending on the other factors which will be there in the individual.
Okay, would topiramate help in metabolic side effects?
Yeah, that's a good point. Yeah, if the patient is having obesity along with the other factors, so we can go with again topiramate for metabolic symptoms. The dose required is around 50 mg. We need not go for higher doses. So definitely it will be helpful.
75 mg, I don't find any response. 200 mg se below काम ही नहीं करता है when it comes to metabolic. That's my clinical experience. What textbook tells is different.
Right.
I don't think it works so well. Anyway,
chewing tobacco versus smoking. So how much is the induction of clozapine, the difference?
It's the smoking. Chewing.
charcoal.
Charcoal, yeah.
She had given a chat. So a lot of questions as he has already answered in the presentation, I think. A lot of things.
Risperidone and clozapine combination 2 times it has been asked.
One question is there,
Lithium.
which narcotic can be used in resistant schizophrenia cases where patient develops pancytopenia with clozapine?
Sorry, I did not hear the question.
That's a very good question.
Yes, sir. So the question is, which antipsychotic can be used in resistant schizophrenia cases if the patient develops pancytopenia with clozapine?
Okay. Yeah, that's a challenging question. The question that we are trying to handle in many of, at least 2 or 3 of my patients. It's just a crazy ride that we'll be taking from there, I suppose. The evidences that I was mentioning, it might be with the higher doses of antipsychotics. Olanzapine is found to be something which is more effective when we have to stop clozapine because of the intolerance. Right. So if olanzapine has not been tried, olanzapine would be the first choice. The second choice will be the amisulpride. And then if both of them are not working, then probably we might have to keep looking for the agents which might be effective in the given individual.
Any role of adding lithium?
Lithium, it will be for acute effect. So it will increase the neutrophil count, but
but I think the
once
mechanism
the person has developed neutropenia, when you are considering that you cannot go ahead with clozapine, if you are in that stage, then lithium might not be too helpful. It will just help for that transient period, and then it will just go away. If you are going for a re-challenge, and then you might want to add lithium, that is something that you can think of. You tried all the other agents, and then you are coming back to clozapine and seeing that clozapine had helped and go for a re-challenge, then probably lithium can be one agent you can be using alongside.
Sriraj, any comments on blinansarine, because it was sometimes said that it can be used as a step up from clozapine.
So some blinansarine and Clozapine, I think both of them were marketed as best alternative to clozapine. I don't think it has stood the test of time, though people do use, and there is some. They're all in case series level. My personal experience is also limited with.
If I can add, I use a lot of blinansarine, Dr. Alim.
Okay.
And for refractory auditory hallucinations, this is the best drug. It is much better than clozapine. If you look at positive symptoms in terms of refractory auditory hallucinations, there's no drug better than blinansarine in the market today. And I've tried and tested in hundreds of patients, and it's my go-to drug when somebody is having auditory hallucinations and refractory to it.
So Sriraj, 2-3 quick questions. Summary of this. Suppose we are finding clozapine patient is not responding to clozapine. So first we have to check for compliance, blood levels, and what else?
Diagnosis.
Review the diagnosis. So we rule out the pseudo-resistant part.
Yeah.
And then we should not wait too much for clozapine. I think you said 2.8 years was one of the cutoffs. Yeah, critical period. So within this period, we should shift over to clozapine.
Yes.
And suppose clozapine is not working, and we want to add other molecules. So in which sort of patients we would add antipsychotics?
So if there are positive symptoms, go for antipsychotics. If the patient is having positive symptoms and alongside significant aggression or even suicidality, which are secondary to the positive symptoms, we'll go for antipsychotics. If the patient is having suicidality, but it seems to be more related to the affective symptoms, primarily the depressive symptoms, go with antidepressants. If the patient is having aggression, agitation, which are not related to the psychopathology, positive symptoms per se, but we see some patients, it could be part of disorganization, so where you see a lot of aggression. Valproate is a best agent. Even in schizophrenia, it has been shown, even non-treatment resistant schizophrenia also, adding valproate is something which will reduce the aggression. So if there is only aggression, we can go for valproate. If there is affective dysregulation, like you are seeing significant depression as well as some amount of hyperactivity, agitation, aggression which are coming up, so probably we can look at lamotrigine.
And with OC symptoms?
OC symptoms, I think we will be looking at antidepressants. I would readily go for escitalopram rather than going with fluoxetine or fluoxamine. It's quite dangerous to go with fluoxetine or fluoxamine. It has to be a cautious choice that we will be making, looking at the holistic picture of how clozapine is working and all other things.
Okay, and memantine and ECT.
ECT is the choice. If we can go for ECT, the positive symptoms are significantly present, they are persisting, we will go with ECT. If it is only the auditory hallucination, Golanzine is something that I have not tried with, which I will start testing for auditory hallucinations after Amritsar's suggestion. But yeah, TDCS, TMS works pretty fine in patients who have not responded to auditory hallucinations. Only auditory hallucination is persisting, but rest of the symptoms are not there. Then no need to go for ECT. We'll go with either TMS or TDCS. Yeah, that would be the kind of choice that we'll be making.
Alim, I'll barge in one question. Cariprazine with clozapine, what is your experience?
Not much, sir. I have not been able to find any positive results till now. It's not been so great. It's not as great as aripiprazole till now. But yeah, my numbers are also limited given the kind of patients that we see, the affordability and all those issues.
So how much add-on effect is there by adding all these molecules and everything? Still, many patients will not respond. So augmentation and combination.
The effect size is very small. As I was mentioning, the effect size is pretty small. The N90 will be pretty high in with any antipsychotic augmentation in the studies, in the RCTs at least. But clinically, if you say, then maybe 1 in 5 to 1 in 10 patients will respond to the antipsychotic augmentation that we'll be seeing, the first antipsychotic augmentation that we'll be trying with the clozapine.
Okay. Thank you. That is all from my side. Yeah.
It's time. We have taken too much.
Samiksha wants to say something.
Yeah, one question I requested again. So from Dr. Gautam, is emerging OCD symptom on clozapine an indication to stop clozapine, or starting anti-obsessive drug would be okay with continuing clozapine?
It's similar to any other side effect. If possible, reduce the dose. If it is really possible, stop, but which generally will not be possible. Then go with the antidepressant. If it is just emerging, then no need to worry about. If it is significantly disabling and if it is at a disorder level, then treat it. If it is not at a disorder level, then let it be for some time. It might sometime come down also.
Okay. So have you seen some rollback, like earlier if the patient was not responding to second generation antipsychotics and you used clozapine to a good level and the side effects were also there, but because of the side effect you had to withdraw clozapine, and then when you restarted with like drugs like amisulpride or something, so did you find it like the patient responded miraculously, something like that? Have you experienced it?
Not much. We have what we can say is there are few patients who will come with clozapine who will be in the 25 mg, 50 mg, 75 mg kind of clozapine they will be on, and they might not be treatment resistance. When we are not able to demonstrate treatment resistance, then we have taken out clozapine and tried other antipsychotics, and we have been able to find a success. There are few patients for whom clozapine we had to stop for multiple reasons. Some patients who had not responded to clozapine at all, and then we did not stop, but they only stopped and come back. So many of them, because we knew that they did not respond at all to clozapine, so we did not go back with clozapine. In few of them, amisulpride helped. But I think most of the patients did manage well on ECT. So there are a subset of patients who are on maintenance ECTs, who are not on clozapine, who are on clozapine, and then we gradually kept them on maintenance ECT. They maintained well on maintenance ECT, so we gradually reduced clozapine and took them completely off the clozapine and maintaining only on ECT. So those kind of cases we have now.
Okay, sir.
I think we should call it a day.
Yes,
Still the questions are coming.
No, we will not take any more questions. It will continue and continue. We can call him again.
Because the topic I think was too interesting. So comments from chairpersons, then we go to Tofan Pati sir.
So to conclude, it was an excellent, wonderful, phenomenal presentation. The audience also kept it interesting with their questions, and we all gained a lot. And the take-home point would be, don't be scared, don't be clozaphobic, be cautious, have a good eye, keep and manage the side effects, and I think patient will benefit from it. And with the new generation as well, I think like during our residency days, we get too scared with Clozapine because courtesy module. But when we come to clinical practice, we realize that Clozapine is actually miraculous and we should not devoid our patients of that. Thank you.
Thank you. Dr. Prerna?
Same from my side. It has been a wonderful 1.5 hours and I have gained a lot. And I look forward to hearing more lectures from you. Thank you so much.
Thank you. Tufan sir?
Thank you very much, Dr. Siraj, for this fantastic, enlightening talk, and Dr. Samikhya and Dr. Prerna for so nicely chairing the session and coordinating the discussion, and also Amrit.
हम लोग को praise कर दीजिए. Thank you.
हाँ वही, also Amrit and Salim, ऐसे कैसे छोड़ सकते हैं हम? So my take is, I would like to comment on Clozapine because I have started the drug day one it came. My clinical practice in psychiatry is of 4 decades. And what I tell is experience-based facts. In my whole practice, I have got 3 cases of Clozapine-induced cytopenia that to moderate degree. And after I usually regularly monitor the blood levels. Initially, we are doing at 15 days, being very much frightened. Now it has increased to 3 months. Usually nothing happens. There may be a genetic protection of our population. And about Clozapine-induced seizures, I have marked 2 or 3 cases when I was in mental hospital. Patients on Clozapine, and out of need we are giving ECT also, though at those times we are taught that it don't give ECT in the patients on Clozapine. Some patients had diminished threshold for seizure, and when they were off the ECT, after some time they showed seizure-like attacks. It was also positive on these. And I have also given Clozapine because I have been practicing in Odisha. Now there are a good number of psychiatrists. Earlier there were quite few. People will come with the untreated psychosis duration more than 3 years, 4 years. At times I try to give them Clozapine straight for our first line choice. And in some of them it clicked. Where it did not click, I deemed it is Clozapine resistant. And because give for 2 months, you write for inadequate dose, believe that they are taking. Because it is very difficult to judge whether they are taking or not without making the blood levels, and we cannot make that. And then you switch over to other antipsychotics, patients respond. Meaning that what I mean to impress upon is that Clozapine can be a first line choice. And in Clozapine cases, if they have not been treated with other antipsychotics, it may work quite well. And the impression of low onset is also quite good. So this is my experience-based addition to whatever enlightening talk I have got from Siraj. Thank you, Siraj, and thank you, Samikhya and Dr. Prerna.
Thank you,
And
sir.
thanks, Alim and Amrit.
Amrit, over to you.
Yeah. Thank you so much, Siraj. It was very exhaustive. There was width, there was depth, there was everything we expect from somebody like you. A great academician, good clinician, and a humble person. Siraj has always been the affable person in our. He was a junior in our residency days, and he still remains like that. So always helpful, always smiling, never raising his voice, the cool person. So thank you, Siraj, for a wonderful presentation. It was really good. Thank you, Dr. Samiksha and Dr. Prerna. You have, taken a sheen out of, because Alim would never allow anybody to speak. He's the person who is always in competition with the speaker. Today, he actually allowed people to take questions, and that's wonderful. So thank you so much for coming and chairing this session and contributing so much. It was really a pleasure to have you. Thank you, Dr. Tufan sir. There's a wonderful topic. And, you look at the number of heads today, we have more than 300 people who had logged in. So this forum is built on base psychiatrists, clinical psychologists, and a lot. So coming to a core psychiatric topic, a molecule, and that too something like beyond Clozapine, having so many people makes us feel so happy that yes, we have people everywhere who wants to hear something good, something new, something innovative, and that's what keeps us going on and on. We hear a lot of negatives also, but then we look at the positives and we march on ahead. Alim and Dr. Tufan sir are the main people behind it. And I'm so happy to see that even after more than 2 years, 2 months, it's going as strong as before. And they take most of the credit. Thank you to all. We have a lot of people who are very dedicated to us. They come, they give us ideas, they give us speakers, they give us topics, and we are thankful to them. Thank you, Torrent. Thank you, IPS OSB, and good night, everybody. I'm just the person who comes to tell thank you to everybody. Thank you. Good night. Take care.
Good night.
Thank you. Thank you, Shiraj, Samiksha,
Thank
Prerna.
you so much,
Bye.
sir.
Good night. Thank you, sir.
That's it.
Closing the meeting
Thank
now.
you very much. Yeah.
Thank you.